Let's begin with something simple but powerful. Take a deep breath in and exhale. Now, think of one reason you chose to study healthcare. Maybe it's helping others or the science or, being part of something bigger. That clarity, your why, it's actually a really powerful learning tool. Today's deep dive is all about caring for those who are most vulnerable. We're talking about people with weakened immune systems. So let's bring that focus as we explore opportunistic infections. This stuff is absolutely critical for pharmacists, med students, nurses, public health professionals too.
Exactly. And our mission today is really a high-yield dive into these infections. We're talking about opportunistic infections, or IS for short. These are the ones that pop up in people with HIV, human immunodeficiency virus, particularly when their immune system, specifically that cell-mediated immunity, that's your T cells doing the work, is compromised, usually because of low CD4 counts. We'll look at the main categories, bacterial, fungal, viral, protozoan. And what's interesting is how we manage them. It kind of falls into three main strategies. There's primary prophylaxis, trying to prevent it from starting in the first place. Then treatment, obviously, getting rid of an active infection. And secondary prophylaxis, sometimes called maintenance therapy, which is all about stopping it from coming back.
Right. And if you're learning about healthcare, this deep dive is just essential. We're hitting core knowledge for anyone in HIV/AIDS care or managing immunocompromised patients generally. Infection prevention, clinical pharmacology, how to use antimicrobials effectively. It's all in here. Plus, yeah, if you're prepping for boards, USMLE, NCLEX, PA boards, or even residency interviews, this will be super valuable. So by the end of this, you'll hopefully be able to recognize the key OIs and what triggers them. You'll understand how those CD4 thresholds link up with specific risks and apply treatment and prevention strategies using, actual clinical reasoning. We'll also touch on important patient safety stuff, drug toxicities, and how to communicate these sometimes complex care plans effectively. And hey, if you find value in these clear, clinically focused deep dives, please do consider subscribing. Whether you're a pharmacy student, a future clinician, or just passionate about infectious disease, this is for you. Your support really helps us grow.
And we should definitely highlight how advancements in ART, antiretroviral therapy, have just fundamentally changed the game for managing OIs. It's quite remarkable.
Okay, perfect. Let's unpack this then. Starting with a foundational overview of OIIs. Like we said, infections happen when the body's defenses, especially that cell-mediated immunity, are down, usually in people with HIV and falling CD4 counts.
It's such a critical concept, and there's this direct link you see. When ART isn't working well, or maybe hasn't been started, CD4 counts drop, and that directly increases the risk of these OIs. But the flip side is true too. Good RT lowers the HIV viral load way down, and importantly, it boosts those CD4 counts back up, which almost always means much better outcomes when you're dealing with an OI. It really shows how treatment transforms things.
So LAK is kind of the cornerstone here. What does that mean for CD4 counts in practice? They aren't just numbers, are they? They're like vital signs telling us which OIs are lurking around the corner at different thresholds. Like you said, below 200, below 100, even below 50 cells per cubic millimeter. It really guides our whole approach.
That's absolutely right. And it leads to the question of management in the clinic. We rely on those three pillars we mentioned earlier. Primary prophylaxis, prevent the first infection. Treatment, get rid of the current one. Secondary prophylaxis, stop it from recurring. And a key principle tying it all together, every OI regimen is very pathogen specific. The drug choice, the dose, how often, how long, it's all tailored to the specific bug and the goal. So effective management means you've got to recognize how these OIs present, which can vary, and know the right drugs to reach for.
Okay, that segues perfectly into our first specific OI, mucocutaneous candidiasis. So this is a fungal infection, usually Candida albicans. It mainly shows up in two ways. You might get oropharyngeal candidiasis, that's usually painless, white patches on the tongue, inside the cheeks. Thrush, often you can scrape it off. But then there's esophageal candidiasis, that's more severe. It causes pain when swallowing Odonophagia. Sometimes you see the oral thrush with it, sometimes not.
Right. Now, for candidiasis, primary prophylaxis, trying to prevent it before it happens, generally not preferred. The risks, things like drug resistance developing or maybe tricky drug interactions, they often outweigh the benefits. And secondary prophylaxis isn't common either, usually just for folks with really severe recurring infections.
So when treatment is needed, what's the first step? For mild oral thrush, we often start with topical things, right? Like clotrimazole, troches, those lozenges, or nystatin suspension. With nystatin, you swish it, hold it, then swallow. They work for mild cases, but compliance can be tough sometimes. The taste isn't great, or it's multiple times a day.
Exactly. So for moderate to severe cases, Or if those topicals just aren't cutting it, fluconazole is usually the go-to drug. Often it's like 100, 200 milligrams daily for maybe 7 to 14 days for oral thrush. A bit higher dose, maybe 200, 400 milligrams daily, and longer duration, like 14, 21 days for esophageal cases. What's really handy about fluconazole is it comes as pills or IV. So if someone has trouble swallowing, the IV option is great. But we do need to watch out for side effects. Elevated LFTs, the liver function test, that's something to monitor. GI upset, rash, those can happen too. And importantly, fluconazole inhibits certain liver enzymes, CYP2C9, 2C19, 3A4. This means it can mess with how other drugs are metabolized. Think warfarin, phenytoin. Got to check those interactions carefully.
And if it's really severe esophageal candidiasis, like it's just not responding to fluconazole, what then? We might need to escalate maybe to IV echinocandins like caspofungin or micafungin.
Yes, those are powerful options. Or even amphotericin B deoxychelate. Though amphotericin, while it's effective, but brings more baggage, kidney toxicity, infusion reactions, often needs pre-medication.
And a clinical pearl here for candidiasis.
Yes, good point. If treatment isn't working, don't just assume resistance. Sometimes other pathogens, non-fungal ones, might be playing a role. It's worth considering.
Okay, good tip. Let's move on. Pneumocystis jirovecii pneumonia, or PJP.
Right, PJP.
Yeah.
Caused by Pneumocystis jirovecii, it's actually a fungus, though we used to think it was a protozoan. Transmission is usually airborne, and it likes to hang out in the lung alveoli, the big risk factor. CD4 count below 200 cells per cubic millimeter. Especially if someone isn't on AAI, or maybe hasn't even been diagnosed with HIV yet, or isn't engaged in care. Symptoms can be really nonspecific, which makes it tricky. Shortness of breath, fever, that classic non-productive cough, chest discomfort. Sometimes the picture is so vague we start treatment just based on clinical suspicion.
So when do we step in to prevent it? Prophylaxis for PJP.
Yes, both primary and secondary prophylaxis are strongly recommended here.
You start primary prophylaxis if the CD4 is below 200, or if the CD4 percentage is below 14%.
Or if the patient has oral thrush or a history of any AIDS-defining illness.
The preferred drug, the real workhorse. Trimethoprim sulfamethoxazole, TMP-SMX.
You probably know it as Bactrim or Sectra, usually a single or double-strength tablet once a day. And it's really crucial to know when you can stop it. Usually if someone's sticking to their RT and their CD4 count stays above 200 for at least 3 months, you can discontinue prophylaxis.
Okay. But you have to restart it if things change.
Exactly. If the CD4 count drops below 100 later on, you restart. Or even if it's between 100 and 200, but their viral load becomes detectable again, you restart prophylaxis.
And safety-wise, with TMP-SMX.
Big one. Stevens-Johnson syndrome, SJS, or TAN, that toxic epidermal necrolysis. Rare but devastating skin reactions.
Yeah.
If that happens, TMP-SMX is stopped permanently. Also, if you're using alternatives like dapsone or primaquine, you must test for G6PD deficiency first.
Ah, the hemolytic anemia risk. Got it.
Now, for treating active PJP, it's a 21-day course. Preferred regimen is still TMP-SMX. Higher dose, though, based on the trimethoprim component, can be given PO or IV.
And kidney function matters here, right?
Absolutely. Dose needs adjusting if CRCL is low. Usually halved if CRCL is under 30. Not recommended if it's below 15. Side effects to watch for: fever, rash, including SGS, again, low blood counts like leukopenia or thrombocytopenia. Also hyperkalemia, high potassium crystalluria, so hydration is important. And liver toxicity. So yeah, requires monitoring. CBC, chemistries, renal function.
And sometimes you need more than just the antibiotic.
Yes, for moderate to severe PJP, adjunctive therapy is key. Corticosteroids, like prednisone or methylprednisolone. Started early, within 72 hours if their oxygen level is low, say PaO2 less than 70. Helps reduce inflammation in the lungs.
Okay, what if someone genuinely can't take TMP-SMX? Allergies or bad side effects?
There are alternatives. Dapsone is one. Pentamidine, usually IV, is another, but it has its own list of potential issues: arrhythmias, kidney problems, blood sugar swings, pancreatitis. Another combo is clindamycin plus primaquine.
Clinda always thinks C, diff risk.
Right. And primaquine, again, that G6PD testing is mandatory because of the hemolytic anemia risk. Ativaquone is another oral option, too.
Wow, okay. Lots to keep track of there. But the core ideas prevent below 200, treat with TMP-SMX if possible, are clear. Let's shift gears to cryptococcal meningitis, or CM.
Okay, CM. This is a really serious infection of the central nervous system.
Yeah.
Caused by Cryptococcus neoformans. It's an encapsulated fungus, looks like yeast. Usually you inhale the spores. We often see it when CD4 counts are kind of low, maybe 50 to 100. But honestly, a lot of patients have CD4s even below 50.
And it's dangerous.
Very. Mortality rates can be high, up to 25%. So getting the diagnosis quickly is vital. We use tests like serum cryptococcal antigen CRAG and blood cultures. Sometimes it spreads to the lungs too, but the main worry is meningitis.
What about preventing it? Primary prophylaxis?
Generally, routine primary prophylaxis isn't recommended. But there's a critical exception.
Yeah.
If you screen someone and their CRAG test comes back positive, even if they seem fine,
What do? You
have to do a lumbar puncture, an LP, and get blood cultures to rule out active meningitis or disseminated disease. Now, if the LP is negative, no active infection in the CSF, but the CRAG was positive.
Then you prophylax.
Yes. Then you start fluconazole, usually 400 milligrams daily, and you continue that until their CD4 count is reliably over 100 while they're on RT, usually for 3 to 6 months.
And restart if the CD4 drops again.
You got it. If CD4 count falls below 100 later, maintenance therapy needs to come back.
Okay. Now, for treating active CM, the disseminated or meningeal kind, you said it's complex, 3 phases.
That's right. And first, there's a non-drug part that's super important, managing intracranial pressure. If the pressure inside the head is high, it needs to be brought down. This often means doing repeated LPs, sometimes daily, to drain fluid and keep the opening pressure below 200 millimeter Hg. It's critical for outcomes.
Okay, vital step. Then the drugs, phase 1.
Phase 1 is induction, lasts about 2 weeks, 14 days. It's aggressive IV therapy, usually amphotericin B, either the regular deoxycholate or the liposomal form, plus flucytosine.
Flucytosine needs a partner drug, right?
Absolutely. Never use flucytosine alone. Resistance develops incredibly fast, and flucytosine can cause bone marrow suppression, so you have to monitor blood counts closely. Also, rash, kidney issues.
Okay, 2 weeks of that intense induction. Then what? Phase 2.
Phase 2 is the suppressive phase, or consolidation phase, lasts about 8 weeks. Here, you typically switch to oral fluconazole, usually 400 milligrams daily.
And phase 3?
Phase 3 is maintenance. This goes on for at least 12 months. It's a lower dose of fluconazole, usually 200 milligrams daily. This long tail is crucial to prevent relapse.
And if it's not meningitis, like just in the lungs?
For non-disseminated, non-meningeal cryptococcosis, fluconazole 400 milligrams daily for a year might be enough.
Got it. Induction, suppressive, maintenance, clear steps. Okay, next up, Toxoplasma gondii.
Toxoplasmosis, yeah. Caused by a protozoan parasite, Toxoplasma gondii. It primarily causes infections in the central nervous system, the brain. How do you get it? Undercooked meat, contaminated shellfish, or contact with cat feces, like cleaning a litter box.
So in healthy people, it's usually no big deal.
Right. Immunocompetent folks often have mild symptoms or none at all. But in people who are immunocompromised, like with AIDS or on immunosuppressant drugs, they're at high risk for acute severe toxoplasmosis.
And the symptoms are neurological?
Typically, yes. Changes in mental status, confusion, disorientation, lethargy, maybe seizures or focal deficits. Diagnosis can be challenging. MRI or CT scans of the brain usually show characteristic ring-enhancing lesions. CSF testing by PCR can help. But sometimes, a definitive diagnosis is hard to pin down. Often, we rely on seeing clinical improvement after starting treatment.
Okay, what about prophylaxis for toxo?
Good news here, the primary prophylaxis regimens for toxo are also effective for PJP, so there's overlap.
When do you start it?
You start primary prophylaxis if 2 conditions are met. The patient has a positive anti-toxoplasma IgG antibody test, meaning they've been exposed before, and their CD4 count is below 100.
And the preferred drug is?
Same as for PJP prophylaxis, TMP-SMX, usually the double-strength DS tablet once daily.
Alternatives exist too?
Yes, like TMP-SMX DS 3 times a week, or single-strength daily,
Yeah.
or dapsone, sometimes combined with pyrimethamine and leucovorin weekly. Hatovaquone is another option.
Oh, leucovorin. That name came up before.
Yes, leucovorin, or folinic acid, is often given with pyrimethamine to help prevent the bone marrow toxicity, the hematologic side effects that pyrimethamine can cause.
Okay. And after someone has had active toxo and finished treatment, do they stay on something?
Yes. After treatment for active infection, they need chronic maintenance therapy. This is typically the combination of pyrimethamine plus leucovorin plus sulfadiazine.
For how long?
You can usually stop chronic maintenance if they've completed their initial therapy course, they're asymptomatic, and their CD4 count has been consistently above 200 for more than 6 months while on RT.
Right. Now, for treating the active infection itself, minimum 6 weeks.
At least 6 weeks, yeah. Longer if the disease is extensive or response is slow.
Yeah.
The preferred treatment regimen is that 3-drug combo, pyrimethamine plus leucovorin plus sulfadiazine.
Okay, watching out for side effects. Pyrimethamine and blood counts.
Exactly. Monitor CBC, platelets. Leucovorin helps mitigate that.
Sulfadiazine.
Can cause rash, including SJS10. Also neutropenia, thrombocytopenia, big one. contraindicated if someone has a sulfa allergy.
So if they are sulfa allergic.
Alternatives include substituting clindamycin or sometimes azithromycin for the sulfadazine. Atovaquone is another possibility.
And sometimes you add other meds.
Yeah, adjunctive therapies might be needed. Corticosteroids if there's significant brain swelling causing mass effect. Antiepileptics if the patient has seizures.
Okay, that makes sense. Last one on our main list, Mycobacterium avium complex, or MA.
Right, MAC. This usually involves Mycobacterium avium and Mycobacterium intracellular. Transmission seems to be mostly through inhalation, maybe from environmental sources like water or soil, rather than ingestion. It often starts in the lungs, but the real problem in severely immunocompromised folks is disseminated disease.
And the risk factor is very low CD4 counts.
Yes, primarily individuals with HIV and CD4 counts below 50 cells per cubic millimeter are most likely to get disseminated MAC, where it spreads beyond the lungs to other organs.
What does disseminated MA symptoms?
Can be pretty nonspecific again. Often GI symptoms like diarrhea, abdominal pain, also weight loss, persistent fever, night sweats, fatigue, anemia. Lab clues might include a high alkaline phosphatase level or worsening anemia, but definitive diagnosis relies on culturing MA from blood or other normally sterile sites like lymph nodes or bone marrow.
Okay, so prophylaxis for MX, recommended below CD4 50.
Yes, primary prophylaxis is recommended for patients with CD4 counts under 50. However, there's nuance here. If RT is started immediately, you generally don't need to start MSD prophylaxis, even if the CD4 is below 50. The RT itself is the best prevention.
Ah, okay. So if someone is on MSC prophylaxis and then starts RT...
You can usually stop the MSC prophylaxis once their viral load becomes undetectable, thanks to the RT.
But restart if things worsen.
Right. If their CD4 drops below 50 again and they lose viral suppression, prophylaxis should be resumed.
What are the options for prophylaxis?
Preferred options are macrolides. Azithromycin, either 1,200 milligrams once weekly or 600 milligrams twice weekly, or clarithromycin 500 milligrams twice daily. Rifabutin daily is an alternative. But you absolutely must rule out active tuberculosis first. Rifabutin can treat TB, but using it alone for MAC prophylaxis could mask underlying TB or lead to resistance if TB is actually present. Big pitfall.
Okay, very important point. Now, for treating active MAC disease, combination therapy.
Yes, always combination therapy, usually at least 2 antimicrobacterial drugs with different mechanisms, and treatment is long, typically at least 12 months. The preferred starting regimen is usually a macrolide like clarithromycin 500 milligrams twice daily, plus ethambutol 15 milligrams daily.
Side effects to watch, clarithromycin.
GI upset, that metallic taste, rash, hearing loss sometimes, and it's a CYP3A4 inhibitor, so watch for drug interactions and potential QTc prolongation.
Ethambutol.
The big one is optic neuritis, inflammation of the optic nerve. Dose-related risk. Can affect vision, color perception, contraindicated if you can't monitor vision. So ideally, an eye exam before starting, and patients need to report any vision changes immediately. If vision changes occur, stop the drug.
And sometimes a third drug is added, rifabutin again.
Yes. Adding rifabutin, 300 milligrams daily, to the clarithromycin and ethambutol is often recommended, especially if the patient has a high mycobacterial load, a lot of bacteria in their blood, or if they're not on effective RT yet. It might improve survival and helps prevent macrolide resistance.
But rifabutin brings interaction risks, especially with clarithromycin.
Definitely. Rifabutin itself affects CYP enzymes, and clarithromycin inhibits CYP3A4, which metabolizes rifabutin, so doses might need adjusting, and close monitoring is essential. Rifampin, another related drug sometimes used in TB, is a potent inducer of many enzymes, causing even more interaction headaches.
Alternatives if clarithromycin can't be used.
Azithromycin, 500 to 600 milligrams daily, can substitute for clarithromycin, paired with ethambutol. In some complex or resistant cases, other drugs might be considered, like certain aminoglycosides, amikacin, or streptomycin, which are injectable and have their own toxicities like kidney and hearing damage that need careful monitoring.
Okay, this has been incredibly thorough, lots of detail on those specific OIs.
Yes, and it's important to stress, like you said, this isn't exhaustive. People living with AIDS can get other OIs too. And therapy is always individualized. The specific drug choices, the doses, depend heavily on how severe the infection is, the patient's overall condition, other meds, kidney function, liver function. It's complex.
And you mentioned pregnancy earlier. That's a special consideration.
Absolutely. Using any medication in pregnancy requires weighing risks and benefits. With antimicrobials for OIs, some have known risks, like TMP-SMX interfering with folic acid metabolism, especially important in the first trimester. So you only use it if the benefit to the mother clearly outweighs the potential risk to the fetus. Always a careful discussion.
That's a really vital point. So maybe let's try to tie some key threads together, big picture takeaways.
Okay, well, CD4 counts below 200 often signal an AIDS diagnosis. That's a key threshold. PJP and MC often present as lung infections, pulmonary issues. Toxoplasmosis is primarily neurological, hitting the brain.
And the role of art is just paramount, right?
Yeah, absolutely fundamental. Successful RT drives down HIV RNA, brings up CD4 counts, and that directly leads to better OI outcomes. It's the cornerstone of preventing and managing these infections.
Then for specifics, candidiasis, often topical, or fluconazole, PJP, usually TMP-SMX for prevention and treatment.
Right. Cryptococcal meningitis, that three-phase approach. Induction suppressive maintenance. Toxoplasmosis prophylaxis often overlaps with PJP using TMP-SMX. Treatment involves pyrimethamine insulfathiazine, usually.
And MSE needs that combo therapy, at least 2 drugs, often clarithromycin plus L-butyl, for a long time.
And maybe circling back to drug interactions, that's a huge theme.
Mhm.
We saw CYP450 enzyme inhibition, like with fluconazole, slowing down other drug metabolism, and induction, like with rifampin or potentially rufabutin, speeding it up. It's a constant consideration with antifungals and antimicrobials.
And mitigating toxicity, too, like using leucovorin.
Exactly. Using non-antimicrobial agents like leucovorin to specifically counteract a side effect like bone marrow suppression from pyrimethamine is a really important strategy for patient safety and tolerability.
So wrapping up, it feels like the whole landscape has changed because of art.
It really has.
Yeah.
RT has fundamentally shifted OI management.
Yeah.
Infections that were once almost uniformly fatal are now, for many people, preventable or manageable chronic conditions.
Which actually leads to a final thought for our listeners to maybe ponder.
Yeah.
Well, with these incredible advancements in art, patients with HIV are living much longer lives. So what new challenges might emerge as they age and manage not just HIV, but other complex chronic conditions alongside it? How does that interact with potential OI risks down the line?
That's a great point. It's an evolving field. As people live longer, we see different patterns of illness, different comorbidities. It definitely requires ongoing vigilance and learning.
Absolutely. Well, thank you for learning with us today. Opportunistic infections really challenge us as clinicians and learners to be alert, to be precise, and also compassionate. The stakes are truly high when someone's immunity is low. If this deep dive helped your understanding, maybe your studying, or even your patient care, please consider subscribing. It supports our mission and helps other people find this free resource. Until next time, stay sharp, stay kind, and keep learning.